Going to hand over the mic to Andy Ann, who is chairing this session. He's an MD PhD student in Bob Hancock's lab. So Andy, you can take it away.
Thanks, Ed. Let me share screen. Okay. So hi, everyone. I'm Andy, a graduate student from the Hancock Lab. First of all, thank you to the CBR Graduate Award Program for allowing me to organize one of these seminars. This seminar is going to be a bit different from other previous seminars that are more research focused because I've invited two lovely patient speakers who I'll introduce later, who are sepsis survivors. And they're going to give a talk about their experiences with sepsis. And I hope this perspective will be very interesting for scientists here to listen to, as unfortunately, there still isn't a lot of patient engagement in academia, and patients really should be a major stakeholder in our research. And so before I introduce the speakers, I want to provide a short introduction as to what sepsis is to provide some context. And so sepsis is defined as a life-threatening organ dysfunction caused by the dysregulated host immune response to an infection. And septic shock, which the speakers will mention, is a more severe form of sepsis with extremely low blood pressure and an increased risk of death. And sepsis usually starts as an infection somewhere in the body, say the lungs, you have maybe a pneumonia, and then it spreads into the bloodstream and becomes systemic. And this systemic infection results in a massive immune response that damages organs and results in symptoms like low blood pressure, delirium, fever, and disseminated intravascular coagulation, just to name a few. And so what it really is this immune response? This immune response has historically been categorized as pro-inflammatory, like a cytokine storm, but years of failed anti-inflammatory therapies for sepsis has led to the understanding that there's also a concurrent immunosuppressive arm of the immune response. And this immunosuppression can last for a very long period of time, making these sepsis survivors more susceptible to another infection, another round of sepsis, and rehospitalization, which increases their chance of death. And so this long-term immune dysregulation in sepsis is what I'm personally studying for my PhD, but it's just one aspect of what is known as post-sepsis syndrome. And I'm only going to briefly discuss post-sepsis syndrome because the patient speakers will do a much better job than me since they are living through that experience. But just briefly, post-sepsis syndrome is this constellation of multiple symptoms affecting multiple organ systems like the heart, the brain, and the kidneys that have been damaged during sepsis. And this ultimately leads to a poor quality of life and increased risk of rehospitalization and mortality. And it's estimated that around half of all sepsis survivors will experience some form of post-sepsis syndrome. But unfortunately, post-sepsis syndrome historically has not been well studied or acknowledged in the medical field. But this is hopefully changing with the increased number of people now suffering from post-acute COVID-19 syndrome, which has quite a few parallels to post-sepsis syndrome, as you can see here. This isn't surprising if you consider COVID-19 to essentially be a form of viral sepsis, considering it is an infection and it results in a dysregulated immune response that causes organ damage. So it checks all the check boxes for sepsis. And it really shouldn't have taken a global pandemic to increase awareness of post-sepsis syndrome, but we're just glad it's getting the attention it deserves now. And with that, I want to introduce Sue Korstad and Marie-Maxime Bergeron to share their stories and thoughts on sepsis and sepsis research. I met Sue and Marie-Maxime through the Action on Sepsis Research Cluster, which is a group of physicians, scientists, and patients doing sepsis research. Sue is a retired registered nurse and Marie-Maxime is a registered dietitian, and both are septic shock survivors who have powerful stories to share. So please welcome Sue and Marie-Maxime.
Thanks, Andy. Can everybody hear me? Just wanted to make sure I'm on. Okay.
Yes.
just to give you a little bit of background, we do belong to the Patient Advisory Council, which is associated with the research network that Andy has mentioned. It was officially established in May 13th, 2020. We are a group of dedicated sepsis survivors who have a keen interest in patient-oriented research and bridging that connection, as Andy has noted, between academia and the public. We definitely see value of the lived experience in the advancement of healthcare, advocacy, teaching, and of course, research. I have given you a link to the Advisory Council. You're more than welcome to go explore it. We do have a third member who I believe has actually joined us today, Christine Russell, and her story is just as powerful and eye-opening. Thank you. Next slide, please. Oh, okay then. So you might be wondering why the photos. We feel it's very important for us to share our stories and bring the human connection to researchers and others that may not share in the direct care of sepsis patients, but in fact play an extremely critical role. Sepsis is a condition that affects not only the patient, but most definitely their loved ones. Firstly, I do consider myself a sepsis warrior. Not for bravery, but for being a fighter and champion to bring attention to sepsis. The photo next to me is my husband, Rob. This was actually taken on our first big trip 2 years later to celebrate my second sepsisversary and survival. We were fortunate enough to sneak a trip into Mexico before COVID hit. Bottom left is a photo of me and my sister, Nancy, on the right. She was crucial in not only being support and care to me while I was in hospital, but caring for my family needs and me upon discharge from hospital. My son, Braden, in the middle, and his girlfriend, Pam. Braden really struggled and has taken a long, long time to deal with the impact that my illness had on him. The fear of losing his mother. I was a single mom. Rob is not his biological dad. And Braden and I have a very unique bond it certainly was a life-altering moment for him. He had lost also my folks who played a big role in his life growing up. Pam was an amazing support for him during my illness. Our beloved cat, Abe, there on the bottom right, he was great company during those long, long days and months of recovery. Do not underestimate the therapeutic value of owning a pet. Next slide, please. So as Andy has mentioned, I am a septic shock survivor. I had abdominal laparoscopic surgery in 2018 to repair a ventral hernia. I have firsthand experience, as you will hear, with post-sepsis syndrome. I am a retired registered nurse for many, many years, and I'm proud to say I actually accomplished my Bachelor's of Science Nursing from UBC at the age of 50. I've been a patient partner on the action of sepsis research actually since spring of 2019, but as noted, we formalized patient partner involvement into the council in 2020. My key interests in sepsis are post-sepsis syndrome, survivor support, research that provides the evidence to help define and legitimize the symptoms of post-sepsis syndrome and survivor experiences, education to increase awareness of sepsis, education to increase sepsis awareness and post-sepsis syndrome, particularly for healthcare providers. As a registered nurse, I'd never heard of post-sepsis syndrome, and following my recovery, I reached out to many of my colleagues, and none of them were aware of post-sepsis syndrome. And yeah, so it is important that we get the word out there. And thanks to my involvement with the cluster, I now have a newfound interest in epigenetics and the research that Andy is doing in post-sepsis syndrome. Next slide, please. So pre-diagnosis, a little bit of a background. As mentioned, I had that hernia repair. Everything went well during surgery. I was discharged with no concerns at the time. I was kept overnight in hospital just for safety precautions. The next day I did well, and about 42 hours post-op, I got up, I wasn't feeling well, and all of a sudden I had this excruciating pain in my abdomen and a sense that something was quite wrong. And that was about 4 o'clock in the morning. I knew that it was probably something that I didn't want to mess around with, trying to get into the car and have my husband in his panic trying to drive me to the hospital. So an ambulance was called and I was taken to the local ER. This was not the hospital in which I had surgery and that my own surgeon was affiliated with. I initially presented with none of the typical sepsis syndromes. I had no fever. My vital signs were stable in, and the concern was severe pain. Personally, I thought I might have had an ileus. My blood work was normal at that time. However, over the next few hours, I quickly deteriorated. It was noted I had no or too little urine output, and my BP dropped to 70/30. They began fluid resuscitations and treatments with IV antibiotics in the emergency room, which was, I believe, a very life-saving action. As the day progressed, my blood work eventually showed a severe elevation of my lactate levels and CRP, and I was diagnosed with septic shock. I was transferred to the ICU later that afternoon. Of high note, I actually have no recall of my time in the emergency room, even though I was apparently answering questions. I was talking to my family, to the staff taking care of me, but I can't pull those memories back. Next slide, please. So I was admitted to the ICU, as noted, to increase my blood pressure with specific medications called pressors and to manage my acute kidney injury, otherwise failure. I was administered copious amounts of IV fluids, antibiotics, and was monitored very closely. I was fortunate enough that I did not require ventilation. I spent what I believe was 5 or 6 days in the ICU with little to no recollections of any of the events in the ICU. It was such a stressful time that my family lost track, and when I asked them sometime later how many days I was actually there, even they were not 100% certain. I fully supported the ICU I fully support that idea that ICU patients should have diaries and that entries can be made by families and nursing staff about the events of the day should they have the time. I have many questions about my time in the ICU. While in the ICU, I required cardiac conversion, meaning they stop your heart and restart it again to bring it back to normal rhythm and rate. This was done twice. I suffered from hallucinations and delusions, including an indescribable fear that I was in harm's way and that the dedicated staff and family taking care of me and supporting me were going to harm me. At one point, I managed to get my hands onto a cell phone and called 911. I was aware enough to make that dial and understand how to do that, but I obviously was not in my right mind. Apparently, I said some pretty nasty things to staff and my family, and my sister and son often remind me about that to this day. I was finally determined, once I was stable enough to have a CT, that I actually had multiple abdominal abscesses from a perforation of what they suspect of my small bowel. A drain was inserted and 5 different types of bacteria were cultured. When I came to, my speech was slow and different, and my husband actually feared I had brain damage. Next slide, please. So here's a few pictures that were taken during my hospital stay. These were actually later into my journey. I have to admit, the first time I saw myself, it was rather upsetting. It was at a second hospital I was transferred to. And when I was finally able and strong enough to be wheeled into the bathroom to sit on a chair and brush my teeth, I looked in the mirror and I broke out crying. It just was overwhelming. And I could see the wasting that had happened on me. Because of the edema, it took until April before I was able to actually see definitions of my toes. And yes, I do have Christmas manicure nails still there from my pedicure at Christmas. Of course, my surgery was middle of February and all hell broke loose. And anyhow, it was worthwhile to take that photo because I was so excited the day that I was finally able to define the digits on my toes. You can still see that there's a significant amount of swelling. Next slide, please. So I was then transferred out of the ICU to a ward, perhaps maybe a bit too soon, but my bed was needed for a ventilated patient. Over the next couple of weeks, I continued to suffer from that extreme pain, edema, inability to mobilize effectively. In spite of my surgical recovery, I was even one night transferred to a medical floor. And again, because the surgical bed was needed. At that point, I no longer was receiving active physiotherapy in spite of asking for it. And in my opinion, in spite of the care that was being provided to me by the staff on that unit, I failed to thrive. I later spiked a fever, elevated white blood count, and a repeat CT scan showed some concerns that required an urgent transfer to a higher level care hospital about 20 miles away, which, as you all know, here in the Lower Mainland, that can become a long commute. And that was a point of fatigue and difficulty for family and friends. I subsequently suffered an enteric cutaneous fistula, and that means a tract from my small bowel developed and eventually opened up into my abdomen with a stoma-like opening. This required cessation of all oral intake, and I was started on TPN, which is a feeding of nutritional products intravenously through a catheter that directly reaches to the right atrium of the heart. I was also told by the dietitian at this time that in fact I was malnourished. I also developed pneumonia, pleural effusions, and heart failure that required massive doses of diuretics to eliminate all the fluids. I still had my tissues from fluids resuscitation in the ICU. Nurses were shocked at the doses and expressed that they'd never administered such high doses of Lasix in their careers. It was worrisome because being a nurse, I was concerned about that as well. I begged to be allowed ice chips, even though they were strictly limited. I was outputting so much urine that I actually broke the handle of the catheter bag one day due to the weight of the urine that quickly accumulated following my bolus of Lasix. And I routinely bypassed the urinary catheter and soaked incontinent pads. Yes, I know that might be a little too much information for some of you, but this indicates exactly how much fluid was retained in my tissues due to septic shock and resuscitation measures. I unfortunately also had a bed sore on my coccyx that had developed during my previous hospitalizations at another hospital the 3 weeks preceding. I also had a small one on my heel. This required extensive treatment and care by a wound management team, and it took about 8 months before it was fully healed. I believe that I may not have gotten such a severe sore, but sepsis debilitated my body's ability to heal. I had drains reinserted into my abdomen to drain the abscesses and was wearing a colostomy device that covered the draining hole in my abdomen that collected bowel fluids that were leaking from the fistula. I was unable to walk, and I required the use of mechanical lifts. And trust me, being hoisted into the air is not in an overly uncomfortable sling is no fun and rather scary. The first few times I sat into a chair, I lasted about 15 minutes before begging to be returned to bed as I was just too tired and unable to cope with the discomforts. I required extensive physiotherapy to regain my mobility. The fatigue and muscle wasting made this an exceedingly difficult part of my recovery. I was hospitalized a total of 58 days. I was not provided any information about sepsis. The focus was totally on management of my draining stoma and wound care. In fact, sepsis was never once mentioned or used by any of my care providers. I had no idea about post-sepsis syndrome and that I would be facing long-term issues. It was probably about 2 years before I was able to put the majority of my health issues behind me and fully enjoy life again. Next slide, please. So again, a few more photos of me in my hospital. When I was allowed at one point some fluids after being NPO for several days, I had a craving for a popsicle, and I was expecting a little simple popsicle to be brought for me, but was joyfully presented with this huge popsicle, and I can tell you it was enjoyed immensely. The picture on the right, it's amazing what goals one needs to achieve to get home. So as a result of all my bowel issues and everything, and I was aiming for a discharge date of April, well, the 24th, the day before my birthday. At one point I was told that it could be late May or June before I even got home. And that was just devastating news, and I was determined that wasn't about to happen. So, of course, one of the functions, and all my nursing colleagues know, and many of physicians will know, that having a good poop is something that is very important before they can discharge you from the hospital. So that was the goal that the nurse and I set for my day, and it was just it was a moment of humor in what had been a very long, difficult journey. And yeah, I just had to capture it. The pictures below were drawn to me by some great nephews of mine. I did have great nursing care. I speak about some incidents that happened, and it's not my point to criticize, but just to bring awareness to the fact that having multiple care providers and being transitioned from wards to wards and then to another hospital can all lead to oversights and things being missed. Okay, next slide, please. So my post-sepsis journey took months and months of recovery, and I suffered many of what is known as post-sepsis syndrome. I had severe muscle wasting and weakness, as noted, the physio in the hospital, but once I was discharged, I also needed support at home to meet my needs. I was unable to complete even the basic activities of daily living without support. I required a mobility walker to go from our bedroom to the living room. It was a terribly slow and tiresome journey filled with many tears of frustration and despair. I felt I would never be myself again. We live in a townhouse complex, and we would measure my endurance and distance by how many garage doors I could get to. It took a good month before I was actually able to make it to the end of our row, where there was an entry to a park where I was able to celebrate. That was a huge celebration for me, being able to make that distance. I spent many hours a day napping. My sister and I have noted basically, the sister who I showed a picture of earlier and have told you, basically put her entire life in Prince Edward Island on hold for about 6 months to be my care provider, family caretaker, cook, chief, and bottle washer. We have nicknamed her our angel. The fatigue persisted for probably 2 years. Initially, I have never experienced fatigue that made just watching TV, eating, and heaven forbid a shower such a challenge. It truly is indescribable, and I honestly hope that none of you ever have to experience that kind of fatigue in your lifetime. I suffered polyneuropathy. Both of my thighs were totally numb for about 18 to 24 months, and I still have numbness and limited sensation in my toes and the balls of my feet. That sometimes causes me to misstep. Of course, any dreams of becoming a ballerina are now totally busted. Shortness of breath and ongoing respiratory issues. Well, given the complications of the pneumonia and pleural effusions, etc., it was months before I could exert myself without being breathless. I continued to have a chronic cough, which right now, as you can appreciate, is not well received when I'm out in public. Hair loss. I know this might seem very trivial, but after all I went through, it was very disturbing and upsetting to start losing my hair. I remember crying with my sister about it and thinking to myself, like, geez, enough is enough. I suffered from insomnia. I would spend nights and nights and nights where I would lie in bed and reminisce about the events that had happened to me, the impact more so to my family, and the effect it had on my life. I still struggle with insomnia to this day, and here I am 3 years later. It's certainly not as often, but I still lay in bed some nights and can't help but go back to that time. It usually ends with me with a big sense of gratitude that I am survived and I'm here and that I have gotten to the point of recovery that I have. The poor memory, brain fog, and short-term memory loss, these were all determining factors that led me to choose to retire from my job as a nursing manager with HealthLink BC. I just felt they were too great of an impairment to be able to return to work and do the job to the standard of which I would want to do and not be an extra burden to my fellow colleagues that might have to pick up slack for my missed moments, et cetera, et cetera. I still have issues with memory and brain fog and can occasionally struggle with concentration for long periods of time. I refuse to admit yet that it is related to aging. After all, I'm only 62. Psychological disorders. I have anxiety when it comes to any change in my health status. A second surgery was required to close my fistula, and I had to postpone it until I felt confident and brave enough to have surgery again. It was a traumatizing prelude that was once a successful surgery that ended up being successful surgery with no problems other than wound healing following. COVID-19 and the fallout has been troublesome for me. What was resolved depression following sepsis resurfaced and required aggressive therapy. Fears of COVID and becoming ill again with severe COVID and or sepsis due to my other health issues triggered me, and a diagnosis of PTSD was determined. Even my family fears any kind of surgery now and the risk of sepsis from any ailments. My husband recently had a cancer diagnosis that will most likely require surgery. Diagnosis is enough, but it's compounded by fears of complications post-op. Sepsis leaves a lifelong impression on patients and families. Please never forget that this illness is a family affair. It had physical, emotional, and financial impacts on my family. Don't get me started on hospital parking fees. My husband was exhausted, working all day and coming to the hospital to visit for an hour or two, then home to eat, and then basically back to bed. I tried to discourage him from daily visits, but he refused to do so. As mentioned, my son struggled a lot, and he didn't want to burden my husband or my sister with his issues, which made it even more difficult for him. We had 4 months earlier lost a brother at the age of 66, and my sister was overwhelmed with the fear of losing her only remaining immediate family that she had left. Again, the human stories we hope support and encourage you all to continue your valued research, knowing the impact it really has. Thank you, and it's now my pleasure to hand you over to Marie-Maxime to share her story. Next slide.
Thank you so much, Sue. Hi, everybody. I just wanted to start by saying that it's an honor for me to be part of the advisory group alongside Sue and Christine, two amazing survivors. Christine is in the audience today. Just because they're amazing humans and survivors, but also their story is much different than mine. I actually turned out pretty good in my situation. So I'm very grateful for that, but also thank you for listening to me today. So my name is Marie-Maxime Bergeron. I live in Quebec. I'm a septic shock survivor that happened almost 2 years ago. I was basically breastfeeding my daughter, and turned out that I had a mastitis from strep A invasive. And I basically went directly to the hospital, and I'll explain all the details. I'm a registered dietitian, so I graduated in 2004. And I've been practicing ever since, and I do a lot of consultations, but also I deliver lots of webinars and seminars. And because of what happened to me, well, I definitely have an interest in post-sepsis nutrition. And being that I also do a lot of patient education, I'd love to do more public speaking and creation of educational materials. Next slide, please. So I'm presenting you 3 pictures, the one of me as a registered dietitian, which gave me this new interest, about post-sepsis nutrition, but also I think part of it also saved my life, and I'll explain why. Also, this is a picture of Celeste. She was a few months before it all happened. So what a blessing in our lives. And then you have a picture of my family. So my husband, Vittorio, that is a native, he's actually from Vancouver. We also have Mila and Celeste. That was taken a few months after my episode. So my sepsis story. Basically, it started with a milk blister on my nipple. It was actually the first time that I had issues. After my 2 daughters, I never had any mastitis, so I wasn't even aware of what it was. I just started having a pain on my nipple for about 3 days, and then in the middle of the night, around 4 o'clock as well, it just woke me up. Like I had this pain in my breast. I was just like, couldn't bear it. And at the same time, really high fever came. And I obviously could not sleep after that. And by mid-morning, I felt like I was literally like dying. I just couldn't even take care of my daughter. My husband had left the home that morning, and he was kind of concerned because I was complaining and saying that, I don't know, I'm feeling like I have a flu at the same time. And I tried to sleep it off. That didn't really work. And then my parents came and took my daughter. I was scheduled to work that night at the clinic, at the medical clinic, and just the idea of doing that was just impossible. So I called to cancel, and at the same time, luckily enough, they said, well, do you want to see a doctor? We have a spot for you. And I'm saying that this saved my life, because I think, especially when it's the first time that you have an infection, you may kind of wait it out. You're not sure what's going on. I don't think I would have went if it wasn't for that appointment. I would have probably tried natural ways or waited a little longer. So basically, I took a Tylenol, and I felt good enough to drive myself to the clinic. I got there, and I usually, like every time that I work there, there's 20 stairs, and I don't take the elevator. And I said to myself, I'm going to do this. So I went up the stairs, and the last stair, I just couldn't do it. I just collapsed. I couldn't even get up. I was on the ground. No one was there around me. And I just took all of my energy. It probably took a good 10 minutes to just grab my Medicare and walk just very slowly to the front of the desk, when the secretary was like, oh my God, what's happening? I just said, I need a bed. So they laid me on the bed. So my doctor came, and he's like, okay, so it's a mastitis, but you're feeling like you have a flu, like maybe you have a gastro, like what's going on? So he's like, you know what, I'm going to get some urine tests done, and we'll check everything out. So he gave me these containers, and I was just going to try to walk to the toilet. And that's when I started vomiting profusely, like 10 times in a row. I couldn't even walk on my own. So they put me back on the bed. And at that point, they verified my blood pressure, and that's when they saw that I was at 70. So at that point, they called the ambulance. Still, they weren't too sure. They're like, listen, you obviously have a mastitis. We're going to send you over. You're going to have your IV of antibiotics, but we're definitely going to look at this blood pressure that you have that's very low. So send me to the emergency very close to the clinic. And at that point, I was starting to get delirious, had a lot of shivers. I was singing Itsy Bitsy Spider to, I don't know, soothe myself, I guess. My husband came, and then it took about 2 or 3 hours later to get the actual, all the fluid resuscitation. In between, they took blood cultures, and I think it took about 4 or 5 hours for them to realize that I was in septic shock. They determined that I also had a really big abscess in my breast, and I needed that to be aspirated, which they did a few hours after that. And that's when I was transferred to the ICU. But at that point, I was actually feeling a lot better. Like, I guess the antibiotics were starting to kick in. And I'm like, I was even talking to the nurses going, okay, I'm going to continue breastfeeding my daughter. And she looked at me, she's like, okay, you definitely don't know what's going on right now. He goes, you have septic shock. So apparently I was already when I came into the hospital, I was already at that stage. So that was probably about 16 hours after I started having the pain in my breast. So next slide, please. So I couldn't produce any urine. I had lots of diarrhea. The doctors saw that I had red spots on my abdomen. I think what also saved me was that they really started asking the question, could it be sepsis? I had an actual doctor from the ICU that came into the emergency. So that would be one point, that's very important, is that they really got input from other doctors, and they questioned that right away. So basically, I got the removal of my abscess, and I was transferred. Next slide, please. So I was transferred, and again, not really understanding why I was transferred, because I was starting to feel actually a lot better. The fever was on and off, but I was starting to get to myself. But what really happened after that was a big wall that just hit me. So my condition actually started improving 4 days after the admission, but if you change the slide, I'll talk a little bit about in between. So I went through multiple organ failures. Mostly the liver and the kidneys were attained. So that was about 2 days in. My phosphate levels were actually very low, to the point that the doctor that was in charge of me was woken up in the middle of the night, just because they have never seen levels like that. I also got some impetigo that came into my face. At that point, it's like I wasn't feeling great anyway, so I'm like, oh my God, my face too. But it's also the aspiration pneumonia that really kicked in, because actually I was doing quite well, and then this started happening about 3 days in, and they think that it was due to all the vomiting that happened a few days before. Also in the whole mix, I was going through sudden withdrawal from exclusively breastfeeding my daughter, which was very difficult physically, but also emotionally. And thankfully enough, they did diagnose that I had invasive strep A about 40 hours in. So they were really able to pinpoint the penicillin that they were going to give me, because at first they were still going really broad spectrum, and they actually changed maybe 3 or 4 times. But when that was determined, I would say that the road of my recovery really went fast. Next slide, please. So I left the hospital after about 6 days in the ICU. Through that process, eating was a challenge. The appetite wasn't there at all, but I was really fed with a lot of IVs, but I was really, unfortunately, released, I found, really fast. There was absolutely no transition. I literally walked out of the ICU. So as much as it went really bad really fast, I also bounced back the other way really fast, but I found a little too fast. Next slide, please. So, like I said, no transition from the ICU. At the same time, there was no investigation in terms of my family members, because this was an invasive strep A, and most probably I got it from my toddler from breastfeeding. So there was no verification on if she had it or any other of my family members. So when I came home, I had tremendous muscle weakness, very, very low appetite, lots of fatigue, and really the anxiety was kicking in. In terms of the aftercare, though, I was monitored very closely with biweekly blood tests, and also I had breast ultrasounds until completion of the treatment. I also was seen by an immunology and infectious disease specialist, and I received a mammogram about 6 months after that. So 2 weeks after I came out of the ICU, I was able to do my regular house chores. 1 month after, I was able to do my favorite activities like wake surfing, which was really like mentally for me like a milestone to be able to do what I used to do and what I loved. And I was a little scared, to be honest, behind a boat and stuff to really have the strength to pull. But I told myself, if I survived, I could do this. So 3 months after, though, unfortunately, I had a really, really bad episode of post-traumatic stress disorder, to the point that I literally took my keys and my purse. I told my husband, I need to breathe. I need some space to myself. I need to really grasp what happened. So I actually went to Vancouver. I took first plane, and left to see his mom and spent a few days there just to kind of recoup. And obviously my family was very concerned about my mental state and my anxiety, my children as well. So I think I needed that time to just grasp it all. So you can change the slide, please. So in terms of my nutrition and sepsis, so definitely I had time to really think about it through, like, how come everything came out so good in my end? Well, I believe that there was definitely a good nutritional status in terms of, my eating habits in general were very good before. So I believe that probably helped a lot of how well I went through this whole ordeal. But also having a high protein and high energy intake through liquids if necessary. So at first it's like a vicious circle. You come back from the ICU, you're weak, Unless really someone actually forces you to eat, you may not eat. So then your recuperation doesn't happen at all. So I really made sure that I had extra calories, lots of protein, and I really boosted everything through liquids. And talking about low appetite, there's many strategies that I use, like having nice odors in the home that encourage appetite, and making sure that you eat every 2 to 3 hours, a very small amount. I was able to really go through the up the hill really fast. And I also had a focus on nutrient dense foods. So I believe that nutrition has a huge impact before and after, and also throughout, but I would say that these are the main key elements that I used through my recovery. Next slide, please. So my thoughts in general, well, what went well in my situation? Well, there's definitely the speed of intervention, but also just the luck of having a doctor the day that I was supposed to work. So that, I think for me, just to be taken on this fast really set the tone for everything else. And also having an early fluid resuscitation and antibiotic, could it be sepsis, which was done about 4 hours in. They did the cultures and then they didn't hesitate. They didn't wait for results. They just started the protocol. And also having those medical follow-ups after that were very thorough. But what could have been better is definitely to do more of a follow-up with the rest of my family, not just in terms of the treatment of the invasive streptococcal A infection, but also how they were coping with the whole situation. And having also no discharge on diet, post-sepsis syndrome or post-traumatic stress syndrome. I had absolutely nothing. And I didn't really have a chance to transition, which I would have wished to have maybe 1 or 2 days at the hospital, but just out of the ICU. So this is my story and my thoughts. And now I'm going to hand back to Sue to discuss more about the post-sepsis syndrome.
Thank you, Marie. So as you all can appreciate, we have shared our stories with you, and you can see from the diagram that Andy shared earlier that we certainly fall into the categories of post-sepsis syndrome. It affects, as we both experience, multi-systems and has resulted in some long-term issues. Current therapies are being, sorry, there's type in front of the screen here, and supported, were very helpful in the recovery process. And definitely future research will improve the outcomes and reduce longer-term effects. Next slide, please. So the importance of research, our thoughts. So we just thought we'd throw some general knowledge that we've acquired along the way and our thoughts about the importance of research with regards to predisposing factors, understanding and research dedicated to many of the illnesses that predispose people to sepsis, such as influenza, COVID, tuberculosis, diarrheal disease, maternal and fetal care, etc. Genetics, blood types, chronic disease, and nutritional status are an area of research that may provide knowledge, specifically the identification of those at greater risk, supportive care, and follow-up for post-sepsis patients. Marie, do you want to do the next slide, please?
Yes, next slide, please. So we wanted to highlight also the rapid testing to confirm sepsis and predict clinical outcomes. So specifically lactate levels, CRP, SOFA scores, which is organ failure assessment, that are not predictive. So the use of epigenetics to identify the endotypes and a predictive prognostics tools that will determine which patients are most likely to have a severe outcome requiring intensive care support. This will then direct care to mitigate complications and hopefully improve patient outcomes. Next slide, please. So in terms of sepsis management and treatment, while there's the importance of targeted therapies, so immunomodular therapies that target specific endotypes seen in sepsis patients, and also protocols that are adapted to therapeutic and diagnostic interventions, and also defining the specific organism responsible for sepsis and the use of the appropriate antibiotics. And also with the ever-increasing antimicrobial resistance, the new therapies, including development of vaccines as the next generation of therapies. And finally, evidence-based research that's supporting care and nutrition. Next slide, please. And I'm going to hand back to Sue.
So with regards to post-sepsis, as I've mentioned previously, that evidence-based research that will support and explain post-sepsis syndrome and post-COVID syndrome. This is critical for survivors battling constant barriers to care and labeling, believe it or not, by healthcare providers that do not believe it exists. There are thousands of anecdotal stories on post-sepsis support groups about post-sepsis patients being denied care, not being believed, and also, and we are now seeing it in also your post-COVID patients, the long-term even financial impacts. I'm aware that apparently even insurance companies are denying long-term care disability claims for some of these patients. Again, because there's not enough documented, peer-reviewed, evidence-based research to support what they are trying to claim that they're suffering from. Gene expression changes that begin early in sepsis and during post-charge. So our question is, how long is there dysfunction of the immune system, and does that play a big role in the impact on longer term care health? We've all offered our blood samples to Andy should he wish to have them and take a further step outside of the current parameters of which he's studying the impacts of post-sepsis. As mentioned, continue research on nutrition post-discharge, and the economic impacts of post-sepsis care will definitely be reduced with greater knowledge and understanding. The more we know, the less these patients, including ourselves, as we've shared with you, will experience long-term issues. Next slide, please. We hope today as patients partners, we have sparked an interest in supporting sepsis and post-sepsis research with the valuable work you do. We've shared with you our personal stories and involvement with the Action on Sepsis Research Cluster, and this has opened many doors and opportunities to speak about sepsis through storytelling and lived experiences. We've spoken to medical students. We are in the process of creating sepsis podcasts and have been actively involved with some input on discharge instructions. We have established connections with post-COVID clinics, Sepsis Canada, and national global sepsis awareness campaigns. We routinely attend meetings held with researchers at the Hancock Lab and are encouraged to ask questions and provide input. And we partake in the annual planning and goal setting for the research cluster, and Marie-Maxime also sits on the steering committee of the cluster. We would encourage you, if not already, to give serious consideration to bringing patient partners into your research. We have hopefully shared with you the value add today. We like to think that we have not only learned and gained so much, but also that our researchers and physician partners have also learned from us. Thank you, and we are open to any questions or comments that you may have.
Thanks, Sue and Marie-Maxime. That was really great, and hopefully everyone can appreciate how much the two of them have struggled and really fought back and got a good result after their sepsis diagnosis. And again, just the similarities between their stories, sort of this sudden onset that led to this, something that they thought might have not been too significant became this really really severe disease, and hopefully that will make people realize that sepsis is not something to disregard, and more research needs to be done, not only during sepsis but after sepsis to deal with the aftermath. So if people have any questions, please type it into the chat, or just mute yourself. But maybe I'll ask a question first as people are thinking of questions to talk about. So I'm really privileged to be able to meet you, the two of you, through the Action on Sepsis Research Cluster. But for people who are studying other diseases who might not have a research cluster like that to engage with patients, what perhaps do you suggest them to do if they did want to engage with other patients that have the disease they're studying?
Was that for us, Andy?
Yeah.
I think it's just There's various areas you can reach out to. There is the Patient Voices Network, which I don't know if your researchers are aware of, that actually they can go on and register with and be hooked up to specific patient partners that might have interest in areas, and they can also have posted their areas of interest and studies in, what's the word I'm looking for? Where they're seeking out patient partners to become involved. That's one of the things that can be done. I think
that's Reach BC. Is that correct?
Pardon?
Reach BC, isn't that another?
Reach BC, I'm sorry if that's correct. It was the Reach BC. See, there's that memory and forgetfulness issue I've talked about. Also, Facebook. Trust me, there's all sorts of, and actually that was one of the first ways I got involved. Olga Pellin and Ova, I can't remember her last name, Andy. She actually posted in a Facebook sepsis survivor page that I was on that she was interested and that there was some research being done. And then through that, I got connected with another advocate for sepsis, Christine Caron, who is with the Canadian Sepsis Foundation. And that eventually got me all linked with the UBC Action on Sepsis cluster. So there are multiple ways that you can probably reach out and connect with patients. Olga Penna, thank you.
Thanks, Sue. Ed, you have a question?
First, I want to thank Sue and Marie-Maxime. That was phenomenal. It's always amazing to get insights from the patients. I'm a physician scientist. I spent enough time in my clinical days in intensive care units and the like to have a distant appreciation, but not from the patient perspective, in spite of taking care of patients subsequently. 2 points. One, I was struck, and only because I'm reading Lisa Genova's book on Remember, about memory. And it's remarkable, and I guess, Sue, you particularly brought it home, that you don't remember anything. And I always wondered about patients when we're wandering around the intensive care unit beds, when we're as a physician or a paramedical person, how much does the patient, and we were by and large fairly careful about what we said and how we treated the patients, obviously, but I always wonder on how much you really do remember, and you don't remember anything, Sue. It's phenomenal.
Yeah, no, I mean, I remember being taken into the ICU. I was admitted to a ward, and that's where they actually inserted the central line, and then they couldn't get my blood pressure up, so that's when they wanted to move me into the ICU for the pressor support. And all I remember is seeing a familiar face. One of the nurses I used to work with actually at one point in a long-term care facility, and Paul had moved. So that was a little bit reassuring. A point of interest, I kind of was taken into a room in which my mother had been in many years previously. And actually she ended up dying as a result of that hospitalization. And I was pretty certain I was being put in the same room, and a momentary thought of, oh, this might not be good. And after that, reassuring my son, because he rushed in once this was all happening to the hospital, because he didn't live at home with us, reassuring him that I was going to be okay. And those were the last words I remember saying.
Interesting.
Yeah.
The second point that I just would like to raise is the importance of an advocate. And you commented on that, particularly when you have an illness that is quasi-chronic, and turns out it certainly is chronic. To have an advocate who can track, monitor, take care of all the transitional activities from place to place, room to room, etc. And that can be a family member, but I think it's incumbent on the institute, our healthcare system, to ensure that somebody can take on that role. It's better for the physicians who are taking care of you at the various steps. It's for continuity of care. It's also important for the patient. And I, as a physician, I recognize how important that really is. And then, as obviously as a family member of patient, of people who have been ill or otherwise, that's important. So as for you as advocates and lobbying groups, I encourage you to, I'd be behind that 100%.
Thank you.
Thank you.
There's a few thank yous in the chat for your stories, and Beverly has a question. She says, as you both have mentioned, recovery can be difficult for patients and also their families. I wondered what kind, if any, support is available when it comes to dealing with neurological issues such as PTSD. What help could have been provided for your families to better handle this?
I think on my end, it would have been maybe that person that was mentioned, someone that's kind of like the middle person that would just tell you that this is a possibility that would happen, just to kind of be aware, and then obviously having resources that are concrete about it. But I think just to mention it, and like Sue was saying, they don't even tell you that you had septic shock. I just saw it on my paper out that I had suffered a septic shock, and they had told me once throughout the whole stay. But other than that, that was about it. So I think it's information about what can happen, what to expect, and obviously the post-traumatic stress, to really be aware of the signs. Probably that would be information that would have been useful.
For me, I also think using greater resources within our healthcare system. In both hospitals, surprisingly enough, I had social workers come talk to me once I was transferred to the second. One was to help me deal with, because initially there was probably some anger as a result of what had all happened to me. I wasn't necessarily casting blame at the surgeon, because I know there's always a risk with surgeries, but it was just some built up, pent up anger about everything that happened. But there was kind of one visit, and because they felt I had family, and she noted in the notes, because I have copies of all my notes from the hospital, that, oh, she had flowers and cards on her window, so she has lots of support. That's a role that I could see that perhaps social workers in the healthcare system could take a role on, a much greater follow-up, and doing post-care follow-up once people are discharged home. I think for both of us, we were left at the mercy of, well, I was at the care of my physician, and so grateful that I have the physician that I have. But many others did not get that kind of support. We're working and trying to work hard to develop post-discharge information that can be given to patients in hospital that have experienced sepsis. We know the post-COVID clinic at Vancouver Coastal has done a remarkable job with discharge summary information. And again, it's unfortunate that it's taken this pandemic and the experiences of our post-COVID fellow colleagues to bring attention to this whole post-illness event that definitely needs better management.
Thank you, Sue and Marie-Maxime. Ed, do we have more time for questions, or?
Yes, you can take one more.
Okay. This is from Eric. It says, this might be more of a question for the scientific area, but are there potential stem cell treatments available for blood count recovery during and post-septic treatment? Maybe I can answer that. To my knowledge, there isn't any treatment available for post-sepsis syndrome specifically, considering that post-sepsis syndrome is really a constellation of a bunch of different symptoms that really should each get their own sort of treatment. But stem cell treatments for blood count recovery during sepsis, again, also, I don't think that there's any research being done for that either. Generally, what actually would happen is the blood, the immune cells in the blood will change during sepsis, but after sepsis will sort of come back to regular levels. But the function of those blood cells is altered. So yeah, so no stem cell treatments really available for sepsis yet, but perhaps something in the future. And with that, I'd like to thank Sue and Marie-Maxime for sharing these stories. I also want to bring attention to something Stephanie posted in the chat for Reach BC for any researchers here who are interested in working with patient partners. So hopefully this talk has really shed some light into the experiences of sepsis survivors and increase awareness of post-sepsis syndrome and the importance of research in sepsis, but also the importance of involving patients in your research. So I hope that was really informative, and thank you everyone for attending.
And thank you, Andy, for coordinating this. Fantastic to all of you.
Thank you.
Thanks, everyone.
Everybody, have a great
Thanks,
day.
everybody.